Hi, in this mind map, we are going to look at liver. So liver diseases are very, very complex and may appear to be very difficult, but I think a good starting point is to look at some of the functions of the normal liver. One of the key functions is in metabolism, and the liver is important in the metabolism of carbohydrates, also of lipids, and of toxins. Toxins may be endogenous or exogenous. An example of an endogenous toxin would be ammonia. Ammonia is produced in the metabolism of amino acids from proteins, and the liver helps to metabolize ammonia to urea, which is then an excretable form. And ammonia, if left in the body, is also a toxin. So drugs and alcohol are important exogenous toxins, particularly alcohol, which can do a lot of things to the liver, as you will learn in this chapter. Now, another key function of the liver is that of the synthesis of proteins. One of the major proteins that the liver synthesizes is albumin. Albumin is very important in maintaining plasma oncotic pressure. Now, another protein that is key to normal homeostasis that the liver produces is clotting factors or coagulation factors. This is actually a series of proteins, without which, of course, we know that the body is then prone to bleeding or coagulopathy. Now, yet another important category of proteins is that of lipoproteins, and I'm not going to elaborate on this, just to mention that this makes sense when you think about one of the patterns of liver injury being that of fatty change. So you can read up about that, and it is linked to lipoproteins. Now, the third important function of the liver is bile production. And why is bile important? Bile helps to emulsify fats. This means that it breaks up the fat into very, very small droplets, which then allow it to be absorbed. Otherwise, it's difficult for the body to absorb fat in the form of larger droplets. Now, for bilirubin, bile helps to excrete bilirubin, and goes back to the entire pathogenesis of jaundice when there's liver dysfunction or when there's excess bilirubin production from the breakdown of red blood cells. So having looked at the major functions of the liver, now we can proceed to look at some of the main clinical manifestations of liver disease. So I'm not going to look at specific symptoms, not so much, more of major clinical manifestations. Some of these are actually clinical pathologic entities, and one of these is hepatitis. Hepatitis can be acute, and of course, where there is acute, there is also chronic. And not only that, it can be fulminant. This fulminant hepatitis often leads to acute liver failure, which can give rise to, of course, death. Now, for hepatitis, how do we know that patients have hepatitis or are presenting with a hepatitic picture? Often, clinically, there may be jaundice. On examination, there may be hepatomegaly, and there may or may not be an accompanying fever. Another way that we can see that there is a hepatitic picture is the liver function tests, which will be abnormal. The liver enzymes will be abnormal. Now, the next major clinical manifestation is liver failure. And liver failure, similar to hepatitis, again, this can be acute or it can be chronic, meaning that it is progressive over years. So fulminant liver failure is an example, fulminant hepatitis is an example of a cause of acute liver failure. And very often the cause is actually toxic, is due to drugs. And as mentioned, there can be chronic progressive liver failure. Now, when we think about some of the clinical signs and symptoms of clinical failure, it would be useful to go back again to this little box here to look at the liver functions. So the liver is unable to metabolize ammonia and get rid of it via urea. What happens is that ammonia is a neurotoxic substance and can give rise to hepatic encephalopathy. And you can read up about the specific clinical signs of hepatic encephalopathy. If we just go down here and we see that liver is important in producing albumin, so if there's not enough albumin, there will be decreased plasma oncotic pressure, and therefore there will be movement of the fluid from the intravascular space into the interstitial or the third space, leading to generalized edema. Clotting factors, similarly, very logically speaking, if the patient is short of clotting factors, there will be a bleeding diathesis or a coagulopathy. And liver failure is one of these things that can, very similar to renal failure, give rise to multi-organ failure, and often the prognosis is very poor for these patients. The third major clinical manifestation is, of course, cirrhosis. Now, cirrhosis is a common endpoint of many of the chronic liver diseases, and we need to first define cirrhosis. This is nodular regeneration of hepatocytes and accompanied by fibrosis. Fibrosis is due to destruction of the liver parenchyma, and at the same time, the third component is architectural disruption. So this is a diffuse disease that affects the entire liver. And portal hypertension is often seen accompanying cirrhosis. And in portal hypertension, the patients will have ascites and they will also have varices. If the varices form in an important site, for example, in the esophagus, they can actually bleed, giving rise to hematemesis, vomiting of blood, which is compounded by the presence of coagulopathy because of decreased clotting factors. So these patients can actually lose a lot of blood. And cirrhosis can also lead to the dreaded hepatocellular carcinoma, which is a complication endpoint of cirrhosis because of the active regeneration of hepatocytes within the nodules. Now, the last symptom or clinical manifestation that we're going to talk about is, of course, jaundice. Jaundice is defined as yellowing of the skin and the sclera due to increased serum bilirubin. There are many causes of jaundice, and it's probably the most simple to divide it into jaundice where there is increased unconjugated bilirubin in the blood and versus increased conjugated bilirubin. So what I've done is I am going to show you a table here from your wonderful textbook, Robbins, and we can see here that the causes of jaundice are nicely divided into unconjugated hyperbilirubinemia versus conjugated. So in unconjugated hyperbilirubinemia, this can be due to excess production of bilirubin. For example, in the anemias, in hemolytic anemia, this is nothing to do with the liver itself, but because there's increased breakdown of red blood cells, this is where our bilirubin comes from. So increased production, the liver can't handle it. Another example would be reduced liver uptake. This can be due to drugs, or it can be due to some inborn errors, for example, metabolic errors like metabolic abnormalities like Gilbert's syndrome. There can also be, at the level of the hepatocytes, also impaired bilirubin conjugation. So, and good example would be physiologic jaundice of the newborn. This is a very common condition that often self-resolves. There can also be genetic abnormalities of enzymes, giving rise to suboptimal conjugation of bilirubin, again, Gilbert syndrome, and a very important cause, diffuse hepatocellular disease. When the hepatocytes are injured, whether it is due to infection from a virus or drugs, or even in cirrhosis, this can give rise to problems in conjugation of bilirubin and therefore increased unconjugated bilirubin. Now, for the predominantly conjugated hyperbilirubinemias, the causes can again be at the level of the hepatocytes. Now, canaliculi are the structures through which the bilirubin is actually excreted, eventually going to the very small bile ducts, bile ductules, and then the bile ducts proper, and then going into the common bile duct and into the gut. That's how the bilirubin is excreted. So if there is abnormal canalicular membrane transporters, then the conjugated bilirubin can get stuck in the hepatocytes. Another important cause is actually physical obstruction, impaired bile flow, and this can be due to intrahepatic or extrahepatic obstruction. Important causes of extrahepatic obstruction would include not too uncommon calculi or stones, and another cause would be tumors. So tumor that can be arising in the bile ducts, for example, or even a non-bile duct tumor such as pancreatic carcinoma. This can arise in the head of the pancreas. It can then compress on the common bile ducts as it passes through the head of the pancreas and give rise to biliary obstruction. Therefore, you have this accumulation of conjugated bilirubin because the bile ducts cannot excrete it into the gut. So clinically, this would be giving rise to obstructive jaundice, and it's important to look at the stool color as well as the urine color in obstructive jaundice. And I'm not going to specifically explain this, but this is something that you may want to read up. Why are the stools or urine a specific color? This has to do with the bilirubin metabolism and its solubility. So here we have the main causes of unconjugated hyperbilirubinemia, which could be due to production or hepatocytic abnormalities, and the causes of predominantly conjugated hyperbilirubinemia, which again can be due to abnormalities at the level of the hepatocytes as well as the bile ducts. So here, just in a nutshell, we've looked at the main liver functions and the main clinical manifestations of liver disease, and the next step is to look at the actual main liver diseases and how to classify them and correlate maybe a little bit with these clinical manifestations.